Hello and welcome. Welcome to Liverpool Medical Institution. I know there's a few people still to come, so we'll start. I'll introduce Sue in a minute, but I thought it might be a good opportunity just to tell you a little bit about this place, because maybe you've not been in here before. My name is Andrew Weeks. I'm a consultant obstetrician over at the Women's Hospital, but there's a turn taking as to who's going to be president of this place, and I didn't get my hand down quickly enough, so I'm president for this year. But it's meant there's been the opportunity of doing a lecture series. Come on in, welcome. Doing a lecture series called Bringing Life. And this is now the 12th of 20 lectures that we've had through the year. And in truth, it's been absolutely fascinating. We've had all sorts talks from the great and the good, whether it's about legal matters, whether it's about compassionate care, whether it's about communication, humanitarian crises. We had a lecture on the other week, antenatal education. So it's been a real opportunity to explore in some depth all the different issues. The place where you are is called the Liverpool Medical Institution, and it started from a journal club. In fact, there was a group of doctors, because of course this predates. If this was first dreamt up 1779, when a journal club got together. Of course, none of these hospitals were built. The university was not even a twinkle in somebody's eye, but some doctors got together from the hospitals here and set up a journal club. And then as that became more popular and they had books together, they said, well, let's put a building together. So this was 1837 that this building was built, and it's continued ever since then as a place of education, a place of meeting together. You may look out outside. We've got it's actually had women at its heart right from the start, which is quite unusual, I think, nationally. There's a lot of these institutions from the 1850s or so, but the first female member was in 1887. We've got a small exhibition you may see just outside the lecture theatre here of famous women of LMI through the years. So that was 87. Then our first vice president, 1926. So women have always been not quite at the heart of it, but so we also have here, which came now nearly 2 years ago, the blood clock. Now, the blood clock was built by an obstetrician, a Scottish obstetrician who people may know of, called Graham Tideman, who's an artist. He did fine art and engineering before he became an obstetrician. But he's built this remarkable piece of art outside, which we were looking at just a little bit back, which is let's just. I'm hoping that everyone's. Yeah, in which blood, artificial blood, I should say, passes down into a conical flask, and then every 6 minutes it tips to release the blood into another chamber, and that represents a maternal death every 6 minutes somewhere around the world. It's quite a startling piece of art, but worth having a look at as you come through. So I've rattled on enough. It's time for me really to introduce Sue. I think Soo Downe will be known to everybody here. She's Professor of Midwifery at the University of Lancashire and has really been at the head of the forefront of thinking and creative thinking and thoughtful processes around midwifery, around maternity care. And so I'm delighted that she's been able to join us tonight. Thank you, Sue, so much for coming. What we'll do is we'll hear from you over 45 minutes, and then there'll be a chance for questions at the end. Those of you online, if you want to put your questions in the chat, then do, and we'll take questions from the room as well. Looking to finish at about 7. Sue, thank you so much.
Thank you very much, Andrew. Thank you for the invitation. I did start with 170 slides, literally 170 slides. So I have taken them down to 55, so I hope we get through them, but we shall see. I mean, if not, I do speak fast, as anybody who's heard me speak before will testify, but I'll try not to speak too fast to get all this in. And thank you to Andrew for the shot. Hello, everybody.
There we go. Okay.
Yeah, and thank you to Andrew for the title for this one, because we were tossing a few titles around, weren't we? And then this one came up and I thought, perfect. So I'm going to be hopefully constructively critical around this notion of, or not notion, this practice of risk assessment during childbirth. And when in relation to this, I'm not talking about women who have pathologies, so women who are epileptic or have diabetes or whatever it happens to be. I'm talking here about what we do where where labour is progressing spontaneously and physiologically, and or what happens towards the end of pregnancy for women and babies who are otherwise healthy, to raise some questions about how we're managing this at the moment now. Move the slide on. I think it just did something with the that's interesting. When I do this, it just makes the web people move up and down intriguingly. Okay, does that help?
Sure that.
Cool. Okay, so benefits. I mean, I'm guessing I don't need to say too much about this in this room, but obviously this is the foundation of where we come with this. So the benefit of risk assessment is to do this: identify pathology, actual and potential, make sure that we've got the right care pathway for the right person, right care, right time, right person, etc. And through all that, to make sure that we optimize outcomes for everybody. And coincidentally, maybe, but actually, in fact, allocating appropriate resources to the care that we provide. And this is just a quote from HSIB, just to kind of underline that point, that basically it's about relying on healthcare providers to recognise a change that increase the level of risk. I have a question here, though. What about decreasing the level of risk? So we often focus on what makes things, we often focus on, well, here we have a healthy woman. What are we looking for that might mean that there's a risk? But there's an alternative way as well. Some risks become resolved. So what about looking for things that might increase her level of health, her and her baby's level of health? And also, what about standardized risk assessment, which increasingly seems to be part of what we do? And clearly, it's important that we don't have too much variation in practice. We need to make sure that there is equity in what we do and that people all around the country get best care. But if we treat everybody as part of a normal distribution, we end up making the assumption that those who are smaller than average or taller than average are by default abnormal, by default have pathology. And in fact, that's not necessarily true. Sometimes they're just small or tall. And I think that's something else for us to bear in mind when we look at this. And I've referenced Ivan Illich, and actually throughout this talk, I've gone back to quite a few old texts, because I think there's things we've forgotten from the past that might be actually helpful for us to remember now going forward. So this was, 50 odd years ago that Illich wrote this, and he talked about iatrogenesis, a word that we all, I think, know, but three kinds of iatrogenesis. So injury by unsafe treatments, medicalization of life, and destroying cultural ways of knowing through over-medicalization. By the way, I don't like the term medicalization or over-medicalization because it implies it's only being done by doctors. And in fact, it's much broader than that, but this term does get used. So you'll hear me use it occasionally, but it's not my preferred term. I like this question. This actually came up in ECPC, Effective Care in Pregnancy and Childbirth, which, as you know, most of you know, maybe some of you don't, the Cochrane collaboration was catalysed by Archie Cochrane giving the wooden spoon to obstetrics for being the least evidence-based profession. And as a consequence, a whole group of people, including Mary Renfrew and Cochrane himself, came together to produce Effective Care in Pregnancy and Childbirth, which was the first evidence-based volume. Like, when I say volume, I mean like the volume, it's like this big, 2 of them, cataloguing all the evidence there was that they could find in various areas of practice. And this particular one, so James and Stewart did a lot of work on risk assessment, and they wrote the chapter around that in the book in ECPC. And they asked this question: although we have a responsibility to ask the question, although we can do this, ought we to do it? And I think that's something else for us to bear in mind as we go through this. I also think it's important for us to go back to think, what is the point? And this is about risk screening, which again is, the two things are very similar: risk assessment, risk screening. What is the basis for a good screening program? So there's 2 slides for this. This is the first one, frequency and severity. That we should, before we do anything else, make sure that all the cost-effective primary preventions have been implemented, and I'll come back to that. We should understand the natural history of the condition, including the psychological implications. There should be a simple, safe, precise, and validated screening test. I'm going to come back to that. We should understand the distribution of test variables in a target population. The test should be acceptable, and there should be agreed policy on the choices available, not the treatment, the choices available, range of treatments, not the treatment, to those who screen positive. This is a bit small, I know. Oh, you can't read it from your end, I think. The screening program should be effective. Benefits should outweigh harms. We should understand the opportunity cost. If we institute the screening program, what can we not do with the resources we're using for that program, for other programs? We should manage the condition optimally. We should be able to manage the condition optimally if we diagnose it. We should evaluate the screening program. We must have enough staff. Those who are taking part in the program must have informed, evidence-based information to make an informed choice. And this one I think is really interesting. Public pressure for widening the eligibility criteria should be anticipated. Decisions should be justified scientifically to the public, which I think in this age of populism is an extremely interesting point. So is what we're doing working? Well, yes, it is. To some extent, it is. So there is a decrease in stillbirth. We should bear in mind that 76% of stillborn babies are premature. So it's not a huge, the effect that we can have on stillborn babies intrapartum is only on 1/4 of babies. And we have reduced it, but about 102 less babies in this analysis, which is Embrace 2025, lost every year, which is fantastic for the parents and of those families. But there's a lot more we could do. There are still 592 babies that are dying every year, despite our successes. Neonatal death, 24 fewer babies, 360 still dying. So yes, maybe we're having an effect, but there's a lot of effect that we're not having so far. Severe brain injuries, this is referrals to the MNSI, which I suppose might not be all babies, but it's still a measure. A difference of 37 babies, so 5 per 100,000 births between 2024 and 25, effectively. And no, so this is a slide on equity, and you can see, I don't know if my pointy thing works, but you can see that there is a narrowing of the gap on inequity for stillbirths, but it's actually almost widening for neonatal deaths, in fact, on this analysis. And the other thing I think for us to bear in mind is how do we benchmark against other countries? So this is neonatal mortality. We are actually not in this table. I don't know why, but our neonatal mortality was about 16% at the time when this table was done, which sits us about here, somewhere like that. And these countries, some of these countries have much lower, for example, cesarean section rates than we do, but much better neonatal mortality rates, which is of interest. And this is maternal deaths. And again, I think we know that maternal deaths are rising, particularly indirect deaths, which is something else, again, that people are very concerned about and we're trying to make a difference to. And the maternal mental health efforts that are being put together are obviously going to contribute to this. But it's still a question. Why are we in this situation where maternal mortality rates are going up? And again, this is a comparison of us to other high and middle income countries where we unfortunately don't do as well as many others do. And some of you may have seen the report that came out yesterday from Birth Rights. So I put in inverted commas psychological implications. That, if you remember, was on the 2 slides with the bit of blocks. One of the things we have to pay attention to when doing this is psychological implications. And what this particular report was saying at the bottom, this culture undermines informed choice, perpetuates racism and causes lasting trauma. And the middle block, as you can say, talks about the blanket application of guidelines, fear of repercussions, inconsistent practices. So again, there's a question to be asked here. What is the balance between standardization and individualization? And at what point might we be doing risk assessments based on standardized guidelines that could be seen as or felt as being coercive? And this particular report also highlights healthcare professionals who are caught in this kind of space where they want to do the best for the individual, but they feel constrained by the organizational emphasis on guidelines. So, consequences for staff, there are consequences for staff of some of this stuff. There's also the question of risk slippage or mission creep. This is actually from the USA, but it's showing the change in parameters for induction of labour by gestational age. And you can see that late term has gone up, post-term is coming down a little bit, actually, but early preterm and late preterm are going up. So again, question about mission creep and what that might mean. And this is I think we know this information again, but I'll just go over it. This is cesarean section us. Now that was 2020, I think, and that was about 30%. We're up here somewhere, aren't we? 46% or whatever it is now. Whereas the rest of Europe, virtually the rest of Europe, is going either flat or going down. So it raises questions about what are the consequences of some of the ways that we're doing risk assessment. Again, inverted commas, because this comes from those slides about what a screening program should do. So benefits should outweigh harms. And what I'm giving you here is, this is an analysis I did on an old paper a long time ago, 2010. This was the famous or infamous wax paper, depending on how you feel, that was looking at home birth, the outcomes of home birth, doing a systematic review. A lot of studies, most of them were not randomized controlled trial studies, but just accepting that the study was done the way it was done. I looked at, okay, what is the balance here? So there were 2 less neonatal deaths for hospital births as opposed to home births, looking at all this data all the way around the world, including places where, high-income countries actually, including places where home birth was supported and where it wasn't. But there was also 80 more preterm babies, 18 more low birth weight babies, 134 more operative births, 86 more cesareans, 60 more episiotomies, 26 more third-degree tears, and 38 more maternal infections. Now, of course, if you're the parent of a neonatal babies that died, you would say that's worth it. That's absolutely worth it. But if you're in the other box, maybe you wouldn't. So I think this is, again, something for us to be thinking about. What are the benefits and what are the risks, and who do they accrue to? And again, I just want to remind you, this is the planned cesarean section versus planned vaginal birth data from NICE. So there are more adverse outcomes in terms of urinary incontinence, fecal incontinence, vaginal tear, obviously, and pain during intrapartum pain, particularly for planned vaginal birth, definitely. There are no adverse outcomes reported in NICE for the baby for planned vaginal birth. There may be some, but they didn't report. Looking at planned cesarean section, you've got far lower numbers per 100,000, but much bigger, much more severe risks. So about 65 more women having hysterectomy, 20 more women maternal deaths, etc. And more risk to the babies of planned cesarean. This is in women who don't have a pre-existing condition. So planned versus planned. There's obviously some issues with the data because it's always difficult to know how planned is planned and what are the if there are no indications cited, does that mean there are no indications? But even so, this is what the data say from NICE. Women should be aware of this, it seems to me. So overdiagnosis and overtreatment, also in italics because it comes from that original screening program, screening slide. This comes from the BMJ, actually. Again, it's an old article, 2012, but it's all about overdiagnosis in healthcare in general. I don't know why I'm getting popping here. I'm popping the mic. Anyway, you can read this, what they said over.
Apologies, that was a problem we had earlier and we weren't.
Oh, it's gone away. Oh, it hasn't gone away. If I stand further back? Back there?
The wires and stuff.
It's the wires. Oh gosh, it's all in the wires. Oh, just got to stay there.
I might do it again just for you. Apologies just online. Just having a bit of process.
Use a different mic, or would that be a problem for the online people?
That might be a problem for the online people.
That's like doing some DIY, doesn't it?
It's no quick fix.
I'm happy to keep going as long as people aren't, as long as it's not too distracting for people online or here. I come to that. This is just a slide to show cesarean section rates and perinatal mortality rates in a range of countries around the world, just again demonstrating the fact that countries with high cesarean section
I
rates.
can't hear you online when you.
I know, yeah, I need to. So I do it like this.
Yeah.
Something like that. So countries with high cesarean section rates here don't necessarily have the lowest perinatal mortality rates. So again, it's how we actually tailor our treatment to make it most effective. I want to also come back to this thing about having a precise and validated screening test, which is also part of the screening criteria. And just refer to ultrasound here, which of course we all use all the time. It's everybody, women love it. It's a great tool, etc. But I think the Big Baby trial was an interesting wake-up call for ultrasound. So in the Big Baby trial, women were randomized into the study if they were diagnosed as having a baby that was bigger than, I think it was 95th centile, something like that. When the babies were born, however, it was accurate only 40% of the time. That is, it would have been more accurate, arguably, to toss a coin than to rely on the ultrasound. I mean, not quite, because obviously 40% of them were actually big. But 60% were not, even though they were told they were. And actually, I've looked previously at the evidence for small babies as well. And, the extremes ultrasound is not terribly good. And in fact, the study itself made this point, the authors made this point. We should be aware fetal weight is an estimate only with substantial margins of error. Now, if we are treating women on the basis of the size and weight of their babies, on the basis of ultrasound, is this a good screening test? I'll just leave that there. And then again, continuous electronic fetal monitoring. I mean, we all know this issue with continuous electronic fetal monitoring. This is the Cochrane review. It's not been updated since because I think there's been no new studies. It's the most up-to-date Cochrane review, and basically, continuous CTG compared with intermittent auscultation, there is an increase in babies fitting, seizures, having neonatal seizures, but there's no difference in overall perinatal death rate or in cerebral palsy rates, and there is an increase in cesarean section. And I think the other thing that people forget about this Cochrane review is that this is true whether the women are low risk or high risk or preterm, and whether you look at high quality or not high quality groups, and whether you have access to fetal blood sampling or not. This is what Cochrane says, it's not what I'm saying. So I think it's something we might need to be conscious of when we think about what our risk assessment is doing and how we're doing it. I also want to have a quick note on demographics, because I think it's become a bit, there's become a little bit of a narrative that the reason we're doing all of this intervention is because women are getting older or fatter or taller or smaller or thinner or whatever they are. And I just wanted to look at this information a bit. So smoking rates during pregnancy have fallen since 2023. So from 8.8% to 6.1%, probably due to saving babies' lives. So we've done some really good work with that. So they are going down. The age of women, which is often cited as being a problem, has changed by 2 years in the last 20 years. So it does seem to be extraordinary that women's age would actually be influencing the steep rise we've had in interventions over the last 10 years. BMI. So BMI in the last, 10 years or so, maybe a bit less, has gone up from 22% to 26%. So 4% change in BMI. Again, it's gone up, but not dramatically. Type 1, type 2 diabetes is quite hard to tell because actually we don't seem to have good data for, say, 10 years ago, as far as I can tell. Maybe I've just missed it. But again, it's about 3.8 per thousand for type 1 and 5.9 for type 2. Not huge numbers. Important, obviously really important that women that have these conditions are treated well, but it isn't the reason. It doesn't seem to be anyway, the whole reason for why we're changing what we're doing in practice. And the slide here is teenage pregnancy rate, which has gone down dramatically. So again, when we talk about that women are getting less healthy, we need to consider all the aspects of their well-being and not just the various things we think are actually getting worse. And we actually need to look at whether they are getting worse or not, or to what extent they are. What about evidence-based information also in that original couple of slides versus coercion? So this is from, which study this was? I can't remember. This was one of the induction studies. It might actually have been the American one, the ARRIVE trial. Or there probably isn't, because actually, sorry, I don't know what the reference of that is. I should have checked before because the ARRIVE trial didn't find a difference. But anyway, generally speaking, in terms of induction of labour, we're talking a number needed to treat for benefit was you had to do between 322 and 1,492 inductions of labour at term or post-term to reduce one perinatal death. Again, at the moment, the evidence seems to show that there are not huge risks to induction of labour. In fact, in the randomized controlled trials, it seems to reduce cesarean section if you think if you think cesarean section is worth reducing. And in the trials, there doesn't seem to be a huge amount of difference between women's experiences. That does seem to be different when you look at the qualitative evidence, I have to say. But anyway, but the point being that actually this graph, which again, women probably should be shown, I don't know if they always are shown, shows the difference between, in the first one, continuing pregnancy with the 2 red dots. So 2 babies dying per 1,000 births if you don't induce at the optimum time, and 1 if you do. So again, many women may still choose to be induced given this information, but many may not, because this is not the same as saying to a woman, your risk is doubled. If you say to a woman, the risk of your baby dying is doubled, almost every woman is going to go for an induction. If you show them this, some won't. And I think that is a different, that's an interesting thing in terms of evidence-based medicine, or evidence-based information. I also thought this was interesting. So I thought for a while, I looked online for induction of labour leaflets. And this is just a very small number of the induction of labour leaflets that I came across. And then I looked for your choices at the end of pregnancy leaflets. None. Now, it seems to me that if you give somebody a leaflet saying induction of labour, you are saying this is the expectation. If you don't want it, you have to opt out. If you give them a leaflet that says your choices at the end of pregnancy, you are treating all those choices as equal. And I think that says something about how we frame our information when we're doing risk assessment with women. What about safety in the longer term? Well, this is now looking at, I'm specifically looking at induction and cesarean section. And by the way, I am not saying these 2 things should not be done. They definitely should be done when they're needed and when women want them. There's no question about that. I'm just talking about this balance between risk and benefit here. So, effects on the microbiome, epigenome, chronic disease. There have been various studies that have looked at, this is specifically cesarean section, and specifically elective cesarean section. Type 1 diabetes and neonate, eczema, asthma, autoimmune diseases, all of these seem to be increased. And of course, we have to bear in mind the risk of these is tiny. Tiny numbers of people have these. Well, certainly in terms of type 1 diabetes, when it says the neonate, that should be the child. And certainly in terms of cancer, although leukemia is a particular one that's being looked at here, childhood leukemia. So, there is an increase, but it's an increase from a very low base. But the fact that there is something, it seems to be, and not every study shows this, but many do, suggests that something is happening with the autoimmune system when we don't go through labour. And then there's the hygiene hypothesis, the microbiome, which again, many people have heard of. And this particular study, in the Canadian child study, which again, some time ago, but it's been repeated since, less bacterial richness and diversity, which might explain, because of the crosstalk between the gut and the immune system, why we're getting maybe this slight increase in autoimmune disease. This one is not often talked about, but this is it has been reported in a number of studies, not least that child study I just showed you. And this is quite a recent one. So 2017 and 2018 reported, this is reported in 2025. An elevated risk of childhood leukemia, again, autoimmune disease potentially. Again, I want to keep re-emphasizing, this is a very low number of babies. We're not talking about big numbers here, but it's just it's a signal that we might need to pay attention to in the noise that we're listening to here. And this is another interesting study, again, quite an old one, looking at foals. God knows why they did this. I have no idea why they did this, but anyway, they did it. They were looking at foals 10 days after the horses had been induced, presumably because they were pedigree horses. I don't know what they do with inducing horses, but anyway. Anyway, they found some very interesting changes that might be associated potentially with this link with diabetes, although of course the link with diabetes was with the cesarean section, which begins to suggest that maybe it's labour that is protective rather than the interventions that are damaging. And that's something else for us to be thinking about. This is one of our studies actually done in an Australian database, a very large Australian database, over 1 million women and babies. And we looked at women who've been induced, again, for uncomplicated pregnancies, and we follow them up at 5 years, and then it's 16 years, a retrospective on this big population-based data set. And we did find an increase in admissions to hospital for infections up to the age of 16 years in babies where the mother had been induced. Again, it fits in with this picture that we're looking at. And the last one I'm going to put you up here is about educational attainment. This is very controversial. So other studies have not found this necessarily. But this was quite a large study that did find a link with school performance. Again, Probably not something that would be terribly evident because, you know, these are very narrow, very small margins. Just an indication, though, that maybe we should be really careful and we should use a precautionary principle when we're using risk assessment and not assume that all the things we're doing are benign. In terms of adequate staffing, I think we all know the situation with staffing at the moment. Again, the slide from the RCM is quite an old study, but the one that Jill Moncrief did, which is this bar chart here, was done relatively recently and published. And the reason for intending to leave, as you can see, wasn't about pay. Pay is somewhere down the list here, but it was largely about not being able to do the job they wanted to do or not having enough staffing. So again, if we're going to introduce or do more and more screening or widen the gap on the screening or widen the gap on the risk assessment, we have to make sure we have the staffing there to make sure that we can do that in a way which is both safe and positive for everybody concerned. Can we learn from our past? I think we need to be just aware of these things so I'm very old. I trained in 1982, between 82 and 85, because I'm a direct entrant, so I'm ancient. And I remember doing a routine episiotomy on all first-time mothers. That was just what you did, routine episiotomy. We wouldn't dream of doing that now. Routine enemas, absolutely, of course, why not? Sleep position, we definitely learned from that. And DES. Now, again, I don't know if you know the story of DES, many of you, but this was given for women who had a threatened miscarriage or were at risk of miscarriage from the 1970s onwards. And it was not effective, did not prevent miscarriage. There's increased rates of infertility, ectopic pregnancy and miscarriage in daughters exposed in utero to DES. There's an elevated risk of carcinoma and a 30% higher risk of breast cancer in those daughters. And the granddaughters are also facing increased risks, again, at smaller numbers. We have to be very careful what we do in labour. And this is pregnancy, but, you know, in pregnancy and labour, because we do not know the consequences, and, you know, it's often until we're at the very long term. So I like this quote, again, it's from a very old document, but I like the fact that it talks about unhelpful, untimely, inappropriate, unnecessary, poorly evaluated interventions. And in this case, I'm talking about risk assessments, but also about those who try to improve the service. This isn't done by people. We don't do all this because we're being, you know, we want to cause harm. We're doing it because we want to improve the service. And that is something that this is at the basis of all of this, I think. So moving on to the kind of final bit of my presentation, really. Every system is perfectly designed to achieve the results it gets. Can we change the conversation? What do women want? Well, we did a review of all languages, all studies, everywhere around the world for the World Health Organization to look at this. And we found that women want a safe, positive experience that fulfills or exceeds prior personal and socio-cultural beliefs and expectations. And that included having a healthy baby, obviously, but it also included, if they could, a physiological labour and birth, but they were also happy to go with the flow if that was needed, as long as they understood why it was happening. And looking at this title as well about cost-effective primary interventions, that was in the original screening data. I think this is another interesting study. It was a summary, a review, or a meta-analysis of 7 trials which were done in low-income countries, where they just got women talking to each other in villages, just talking to each other about various things. And they found that there was a 37% less maternal mortality, and this was common across all the countries in which it was done, and a 23% less neonatal mortality. And this wasn't just because women went to the hospitals more, though some did. It was because they shared health information, they built relationships, and they shared knowledge and experience amongst themselves to be able to care for themselves in ways that were actually positive without necessarily needing to have other higher level interventions done or held. We should optimize the clinical management of the condition, and we should remember that actually labour and birth is an interactive, dynamic, interconnecting process. We can't just separate out a big baby from a mother, because actually the way that woman labours will dictate how that baby might be born, unless it's, you know, obviously above the brim and, you know, huge and isn't going to be born. But generally speaking, it's the interaction between the mother and the baby that we need to pay attention to. And also we need to understand what happens towards the end of pregnancy to get the baby and the mother ready for pregnancy. And what do we lose if we induce labour earlier and earlier, potentially? And I was very excited to learn about uterine gap junctions and how these increase up to labour onset to increase the potential for oxytocin to have a positive effect. And this is just another study on done in rats, which demonstrated that actually a change in GABA actions enabled oxytocin to protect the fetus in labour from anoxic episodes, which I think is another interesting one for us to bear in mind. I know I haven't got time to go through this, but if you have a chance to look at this particular link, and you have the slides later, there's some very interesting data on the difference between the effect in the body of endogenous versus exogenous oxytocin, even though they're the same chemical compound, primarily to do with the way it translates into the maternal brain. But you might be interested in that for future reference. So, could spontaneous labour onset and progress be a positive physiological and psychological triggering process? Maybe. And if it is, should we ignore it at our peril? Could we start thinking differently? So rather than thinking about how things go wrong, which is a focus of safety 1 in this red box here that most of the time we pay attention to, might we also look at safety 2? How do we make as many things as possible go right? So both controlling the few things as possible that go wrong, but not then overextending the solution to that so that we get in the way of things that are currently going right. And how does that link with evidence-based medicine, which is the integration of best evidence with clinical expertise and patient values? Bringing those things together optimizes quality of life. So I don't know if I have time for this. Do I have time for this? Have I got 5 minutes?
Yep.
I just want to play this. This is Nicola, who had a very traumatic first labour and birth. And when it came, she was booked with a community, a continuity carer team for her second pregnancy because of this. So she, in terms of that, getting things right beforehand, before doing the screening piece, that was in there. And then when it came to her labour, she laboured in hospital. And when it came to labour and pushing, she couldn't push the baby out because she felt psychologically she couldn't, because she had very severe perineal tears and repairs with her previous baby. And so what the obstetrician did, the consultant did, is she integrated her clinical expertise, Nicola's values, and the evidence she knew of the physiology of labour and birth to create a positive experience for Nicola, which actually solved her, oops, if I can make it work, see, which actually put to bed partly what happened to her before. And this was a risk assessment that was done on the hoof, if you like.
The difference in her was that after she discussed everything with Anita, and I remember hearing Anita saying to her, she was going to lie on her back. I remember hearing her saying that. She came up to me and Mrs. Martin, she put her arm around me and she said, right, this is what we're going to do. She says, I want to know whether it's okay with you. And she said, what I'm planning on doing is, with your next contraction, I'll put the forceps on his head. The following contraction after that, just pull his head around the new bed a little bit, and then I'll take him off and you can do the rest yourself. And she said, is that okay with you? What do you think? And I thought, I think somebody's asking me what I think. I said, yeah, that's fine, just do it. And I said to her, do you need to cut me? Because I thought, I felt sick at the doctor's arm again. That was just too much. And she said, no, I don't. And I said, do I have to lie on my back? And she said, well, it probably would be easier for me, but we'll try it underneath it to start with. And I said, I don't want to lie on my back at all. I really, really don't. And she said, I know, it's okay, we'll try it like this. So that's what she did. She lay on the floor underneath me, kind of like a mechanical sleep car, really. And she did exactly as she described. And I felt the forceps going on, but it wasn't painful at all. And I was expecting it to be really excruciating and painful, but it wasn't. And as she pulled his head around, I just felt him kind of slot into place. Well, I can't really describe it, that there's anything else other than that. And then the next contraction, as I pushed, I could feel him manoeuvring downwards then. It was as if she did something for me, not that it was easy for her as a doctor. She did it for me, and she went out of her way to make sure that I really got what I wanted. And in that respect, I was after the event, I just thought, oh, God, she did that. I'm really, really pleased that she did it. And I can only hope that, and I'm sure she has, and I know that she has, that she'll do it for other women as well, so that they get what they want, and they don't end up flat on the back with a piece of me in a third degree there as well. Because I'm absolutely convinced that because she did that, I didn't care, because I was thinking to myself, oh my God, I'm going to talk in front of the back. I was absolutely petrified that was going to be the situation that I would be in again. I need to start saying, let's lie in bed and let me have a look and check out to see if you need any suturing or anything. I was thinking, please God, please let this be all right. And I remember saying, you've just got a couple of 2 grey areas and you've got one tiny little it's minuscule. I can put one stitch in it if you want, or I could leave it and just let it heal on its own. But it might sting when you have a week. I said, oh, I'll just pull it together then. And she literally did one suture for me, and I couldn't believe it. I was over the moon that I didn't end up being a patchwork quilt again like I was first time round. But I'm absolutely 100% sure it's because of the fact that she lay down on the floor underneath me. I'm sure it wasn't a delightful view for her at all, but she did something for me, and that's I'll always remember that for the rest of my life. And she won't, because she probably doesn't even remember what I look like now, but I will remember that forever. And she kind of, in a way, it's kind of not that I've forgotten about the first one, because I'll always be there, but it doesn't feel as bad to me anymore because I've got some resolution by the way that the second one was handled, and it was handled in a completely different way.
And this is actually Liz Martindale reenacting that particular forceps. So teamwork and positive relationships in action. So just one final point before I finish. Maybe one thing we were just discussing this earlier on. One way we could move forward into the future with this is we could use the power of AI to have much more precise individualization of risk assessment. So that, for example, in that big graph with 1,000 and the one, we could actually have maybe 100 women that need to be induced for the one that might need to be, you know, to make a difference to the neonatal death rate, so that we don't lose that other baby. Maybe we could, or maybe the other 900 women could be found not to need any intervention, or that they don't want anyway. We don't know, but it may be that there's a future that we could tap into that takes us into a different space, building on AI for all the problems it might bring for us, with the ultimate aim of this, making sure that we do get the best outcomes for everybody in the short and the longer term, for the resources we've got, and with happy staff who are doing a job in which they feel joy, and where they can exercise their skills in a way that they feel is appropriate. Thank you.
Thank you so much, Sue. Don't go away. I think we can probably both stand here. So we've got some time for questions and for discussion. Is there anybody in the room? There's been comments online, 37 things online. So we'll try and pick these up at the same time as we take questions in the room. Can I start then? Let me start the ball rolling, because one of the communicating risk I find is always very difficult. And you talked to those infographics are great. But often when we communicate risk, we either use diagrams or we communicate using a number, and we say your risk of this is 1 in 500, your risk of this is 1 in, and the numbers must just tear people's. It's almost too much that you're throwing hundreds of numbers at people and it just washes over, and it's sort of false information. And when we were doing work on consent, we found that actually the best, what people wanted actually was a trusting relationship.
Yes, definitely.
And actually it was that trusting relationship with somebody you knew and who, I don't mind what the numbers are. You're the technician. You are you happy with, you know, if you're happy to do it to me, then I'm happy. And it was that trust. And actually the numbers actually didn't really come into it. And we're, in a sense, we're conning people almost by throwing lots of numbers at them, that therefore they understand the risk. That's all right, I've tick boxed, I've told them everything, and therefore legally I'm protected. And actually, really, that's not terribly helpful at all. And I wonder whether we should be getting away completely from the numbers if we could get that trusting personal relationship with people. That, to me, that's what I would want from a surgeon who is operating on me. I don't want them to give me a load of risk statistics. I want to have somebody I trust and who I know is doing their best for me and actually keep the numbers away from me. And I'm an academic.
I think it depends. Some women and families do want numbers. They do like numbers, and actually some fathers really do like numbers. So I think if we've got them, we should give them, or we should give them accurately. But obviously I'm not going to disagree with you about the trusting relationship. I think that is the cardinal thing here. And if we can get that right, and of course continuity is the obvious way of doing it, whether continuity with an obstetric team or with a midwife or a midwifery team, then you're much more likely to get a collaboration between the two that's going to end up with optimal outcomes, whatever. And I think the other bottom line on all of this with the numbers is that it kind of implies you get to the point where you think, well, actually, well, I suppose one of the things that we need to be more courageous about saying is there is always going to be risk. There is always going to be risk. So we could reduce the risk to 1 in a million. And women may still say, I don't want to take that risk. It doesn't matter. There's always going to be, and there'll be a risk with cesarean section, there'll be a risk with induction, there'll be a risk with physiological labour and birth, there'll be a risk at home, there'll be a risk in hospital. There is never no risk. I think that is something that if you're talking about conning people, I think we're beginning to con people to think there is no risk. And I don't think that's true. I think we have to be careful to say, this is an uncertain process, wherever you start with it, really.
Well, we have that whenever we do a cesarean section in a hospital. We've got a long list of things that we have to say, and one of them is that your risk of a hysterectomy of your cesarean section is 1 in 1,000. Now, that always seemed to be a con, and I hope there's no noise listening. But I always say at the time, but for you, actually, this is your first cesarean. You're otherwise completely healthy. You're not the sort of people who gets a hysterectomy in the middle of your cesarean. We usually know who those people are. There's very few who are sort of unexpected.
Well, this is where the precision stuff comes in, isn't it?
So you're taking a whole population data and you're applying it sort of to wrong women. And
also you're applying it, I mean, different hospitals, not necessarily, I suppose, hysterectomy, but different hospitals have different rates of some of the more common outcomes. Indeed. So, it may be that in that particular place they're going to, it might be more or less. So I think precision, again, having some precision information, if you're going to go with numbers, for the place they're going to, even at the level of the team they're going to, and certainly for them in terms of their particular, are they healthy themselves? Do they play sport? A whole range of different things that might go into an algorithm that might help people to really understand where they fit in that thing. But even then, some women who have absolutely no risk factors will end up with those outcomes.
But you can't say it's 1 in 1,000.
No.
Or it's suddenly much less. Whereas somebody who's got placenta accreta and all sorts of horrors, your risk may be, I don't know, 10%.
Yeah, but if it's you, it's 100%.
Well,
whatever happens. Yeah.
Well, anyone online? There's a lot of questions coming through online. Please, yes. What? We actually have a microphone here because otherwise they can't hear online. Let's just get these microphones.
Thank you. So I'd like to ask you the question about the line between the standardization and the precision. In the UK and in many settings, whenever there are incidents, people will compare against the standard. So when they are doing audit, so how can we reach at that line of demarcation so that the caring is still acceptable?
I think that's a really interesting question. And I think, obviously, again, you don't need me to tell you this. There's so much defensive practice because people are afraid of that particular, either the audit or the social media or the press or whatever, saying you didn't do what the guidelines said or you didn't do, whatever the kind of standard procedure is. I mean, I think in the end, certainly as a midwife, I have to abide by my code of practice. And my code of practice is that I must not allow harm to happen I certainly mustn't cause harm to the people that I'm not practicing clinically now, but when I was practicing clinically. So I would make the decision, a bit like Andrew says, in collaboration with the woman, so that there was a kind of joint decision making that was happening with her and her family or birthing person. That still won't protect you necessarily from being sued. And I think ultimately we have to accept the fact that we either decide that we're going to practice defensively in the hope of not being sued, which won't always be true because sometimes we still will be sued, or we're going to practice according to our ethos and ethics. And that may expose us in a different way. So I would say on a personal level, that's how I would handle it. on a kind of system level, I think this kind of debate needs to be had much more. It needs to be had with the politicians, needs to be had with the press, needs to be had with the lawyers. So we had a very interesting project that was funded by the Gates Foundation, where we said the problem it was around cesarean section and fear of litigation in India, because in Telangana province in India, the cesarean section rate is 80%, I think, something like that. Certainly in the private, I think even in the public hospitals, it's extremely high. Whereas in some parts of India, it's 4%, which is obviously far too low. So there's this huge inequality. So the kind of solution tended to be, well, let's go and talk to the obstetricians and sort them out. And we said, actually, no, let's talk to the lawyers, in fact, and let's get the lawyers talking to the obstetricians, because actually that's where the dialogue needs to be, because that's where the misunderstanding is. And it was an extremely interesting project that we'd like to continue in other countries. So I think that my long answer to your question is we need to be working on various levels. So what we do as practitioners, as individuals, and what we think is right for our consciences, and how far we can tolerate that in terms of our own risk appreciation. And then we need to work at a systems level to be able to change the environment so that we're not feeling pressured into doing things that we know might be causing harm, or that are coercive, which of course we should never be doing. We should never be doing anything that's coercive. Yeah.
Just going through, I was trying to read through the questions while we were talking, and actually a lot of discussion then about risk communication. How do we best communicate risk? We need a continuously updated resource related to risk rates for interventions, which of course would be brilliant if you can get the number right. And I think so often the number we band around the numbers, and actually the numbers are mind blowing and don't help. But secondly, they don't relate to that individual. So, but a continually updated resource would be useful, I think. One of the things I wanted to ask about was about interpretation services and these discussions, because I personally, in my clinical work, I find that the most difficult thing. Normally, when I'm going through a consent form, we're talking with somebody and we just talk through it, and I'm afraid it's a bit of a monologue. I say, look, there's these things, you need to be careful of this very rarely happens, but we'll look out for that, etc., etc. So we go through it, and it's a bit of a monologue, but it's 5 minutes worth, and that's fine. If I'm doing it through an interpreter, then I read the first line, the interpreter interprets it, and because I've paused, she then asks a question.
Right, interesting.
Which then comes back to me, and I'm, yes, well, and we're only on the first line, and I think, oh my goodness, I've got a line of 20 people waiting, and I'm only on the first sentence.
But doesn't that illustrate the fact that the monologue is not actually informed choice, because the women are not asking questions when in fact they probably would if they had that pause.
That may be true. That may be true. But it means there's no lawyers asking. But it means often you end up skimping a little bit on the consent process because you're 20 minutes into it and you're part of a long dialogue. And you think, I just can't do this. We're already late for the section list. So it's quite interesting trying to communicate risk in a different language. And certainly information, to my mind, if you had written information which was continuously updated, but also that trusting relationship, and it worries me that the trusting relationship is at a very difficult point at the moment for multiple reasons.
Yeah, definitely.
And it's even more difficult in non-English speakers.
But going back to that, again, I think this is where technology can really help, actually. So there are systems now where you can talk into your phone and it translates automatically to the other person. So, you can just have a natural conversation. I speak in English, they speak in German. We hear each other within a very short period of time. I think that would be widely available. So I actually think the translation thing, but I think the issue is much more than the translation thing. I think it's the time to have that conversation. And as you say, the trouble is if you have a continuous relationship, then you're talking about these things all the way through. You're not doing it at the last minute in a room when you're busy doing something else. You're having that conversation, the last clinic appointment you saw them, or the time before, or whatever. So you're not having to put it all into one box at one time because you've not seen them before. So I think the solution is far more fundamental, really. Yeah. And
that's always been the thing about, I think everybody agrees that consent needs to be a continuous process, not a tick box exercise with 5 minutes as you're running into theatre. But actually, if you've done it to somebody, that's exactly the wrong term. But if you've had a consent discussion with somebody, I have it at the next clinic appointment. I have no idea what you said.
Yeah.
So if you don't have the continuity, then it's almost impossible to get the consent process right as a continual discussion.
That time limitation is that you are forced to just discuss risks, and you're not able to talk about how the woman feels, what her values are. I mean, obviously, if it's an emergency section, it's different. But when it's something that, like induction of labour, where you're thinking, got a few weeks before to have a conversation, it may well be that she she tells you things that you think, actually, in her case, this might not be such a good thing, or it might be good to do it this way and not that way, or one day later, or a week later, or whatever. But if you haven't got the time for the conversation, you can't bring her perspective into it. So your risk assessment becomes very partial, doesn't it?
No, indeed, indeed. Oh, goodness, I'm never going to be able to. Apologies for those online. There's loads of stuff coming up online, which is fascinating. But are there any questions in the room at the moment?
Comments or disagreements?
Carol, have we got the microphone there? They were having difficulty hearing online. No. She said, "Can we hear her now?" The answer was no. There we go. How's that? Is that any better? Yeah, brilliant.
I'm very talk recently, and she's talking about her education and confirmation set. Vicky Bradley's done some work on this communication with women and clinicians recently about how they want this communicated was one thing that I just want to say people weren't aware of that work, because I'm not sure if she's joined online or not. I know she really wanted to. And the other thing was the take home is not just how risk is communicated, it's the care in the room at the time. Because hearing women say, "I will remember that for the rest of my life," I think that really hits home. Thank you.
Yeah, I agree.
Thank you. Yeah. Thank you. And there was another comment from Jane at the back. Can people hear online? Is that coming through? No, there's a microphone turned off. Yeah. They're answering on no, yes, not really. No. So speak up, please, so they can hear online.
Thank you so much. And it was just a comment really about it again. And I run a birth choices clinic at the moment, so I do a lot of discussions around choice and birth options really. And I always think that risk is very personal as well. So I can often have a very similar conversation with a clinical circumstance with maybe 3 or 4 different families, and their responses will be really different. And I do always try and share numbers and data. I think for some families that's really helpful for them to contextualise how big or small is that risk for me. But I think really the most important thing is that women feel listened to, and they feel supported in their choice, and they have time as well. So we do try, and know a lot of the information around in the media now is that actually women are not listened to, and I know there's a lot of evidence from maternal voice that is true. But it's really just as well to just reassure from a clinical perspective that actually we really are trying hard in studying for education, like the options, studying the planet, studying one that's just around use it, the women's about their section and be down delivery, that we are really trying to spend a little bit more time to talk to women and share risk but in a balanced way. So just that it's very personal as well.
Definitely, yeah, absolutely.
So they've asked if we can repeat online. So I shall try. So this is Jane, who runs the Birth Options Clinic here in Liverpool. Does a wonderful job. So, but is talking about communicating risk with and how difficult it is, and how you need really to personalize it and tailor it to the particular conversation you're having. You do use numbers, you do add the numbers, because that helps give some sense of the enormity or the scale of it. But actually, a lot of it is about getting that, making sure that women feel listened to, that you're not just dismissing any concerns they've got, and that then takes time.
Well, so we never want to feel the pressure to make a decision right away.
Okay.
So we always kind of
So follow-up appointments as well also being important. So you're passing, you're communicating, you're having that discussion, then giving them time and follow-up. But that takes enormous time, doesn't it?
It does, and that's what we need. I just want to point out as well that one of Carol's
definitely worth it. But
Yeah.
if we've got the time, if
one of Carol's reviews, but which one of yours was it? They said that women want a whole range of different education options. So they wanted, it was one of the WHO reviews. Yeah. Yeah.
Anything that is global, but it's quite old now. But saying it's old now actually is exactly.
we got the microphone.
Yeah.
Still might have to repeat.
Thank you. Yeah. So it's a 2018 review that's old now, but it's global. But saying that, it's exactly what we hear in local children's centres now, that women actually, yes, they like the online, they know there's a lot of information in there, but you go down a rabbit hole and you start looking for this information online. So actually, structured information like the core information sets is actually manageable and available online, available in paper, in all these different formats.
Yeah. So to take away from the consultation to look at it, as you say, in different fora and different ways. So as many ways as I guess we should produce the information in as many ways as possible, and with as many graphics as possible, so that it can appeal to the way people learn, because they learn in different ways, don't they? We also have this thing of decision fatigue as well, though. That I think there are many women that by the time they get to the end of pregnancy, they're so fed up of being asked to make decisions about screening test after screening test, after risk assessment, after whatever. That's when they go, oh, just do what you could, just do it, which is not the same as your just do it. As in, you're right, I trust you. It's like, I really don't have the headspace anymore to make any more decisions here.
Yeah.
So, I think that's where the time thing comes in. And to an extent, you're right that we don't have the time, because we're running around doing so many other things we shouldn't be doing all the time. So I just want to, there's a very brief example of a study that I'm on the steering committee of, and they were doing some observation. And in one particular trust, they found that the midwives had to, every time they put anything in the computer for 15 minutes, they had to leave the labouring woman, go outside where the computer was, take their gloves off, put their password in, put the information in the computer, put their gloves back on, shut the computer down, go back in the room. If you're doing that every 15 minutes, you're not with the woman. You're not giving her time. So, again, I think there's a programme in Manchester where they're trialling natural language processing, where you talk to a tablet, just a narrative of what's going on in the room, and the programme picks up the important data and dumps it into the system. So you never have to leave the room. Now, isn't that fantastic? So, I do think that there are technical solutions to some of this stuff, and there are enough stuff and there is enough time. It's just that we're not doing the right things with that time, I think.
No, it's a good comment. Thank you. I'm aware that we're already 7:05. We're supposed to have finished at 7. Clearly, this is never going to finish the conversation, and almost these lectures are a way of raising the conversation and getting people thinking. And I hope this has been thought-provoking. It certainly has been for me and for those in the room. And looking at, I'll maybe just keep the computer on for a little bit, because there's so much good stuff online that people can then have a look. Interesting comments then about salutary information, so positive information rather than risk information, and how we get that balance right. But that would take us another 20 minutes to say. So I think we need to finish there. Sue, everyone who comes, we give a little gift to say thank you very much for coming. Thank you for coming all the way down from Preston. It's lovely to see you.
Yeah. Can we keep the comments? Is there any way of saving those comments?
I don't know. We shall speak to the IT whiz, Sam, who is here. So next Friday, in fact, we have the next of our lectures, which is all about humanism in surgery. So how do you get humanism in surgery? And it's going to be quite interesting. A former president of LMI in 1956 was Brian McFarlane, and this is his son, who is now a professor in Madrid, who's coming to talk to us about humanism in surgery. For those of you interested in continuing following through this, whether you're at home and you wanted to join online, or whether you're coming in person, if you go to the lmi.org.uk website, then it's got a list of the remaining 8 lectures, which are being held up until June. Or be a member. Come and be a member of LMI. It's kept going on subscriptions only, and by people renting out spaces. There's no core funding. It's us to keep it going if we want to. Membership's open to everybody. £50 a year, which is a lot, but it's not a lot given what we have here. And so free to medical students, free to midwifery students, free to nursing students. So do come along and join and be part of it. Yeah, and so until next Friday, we'll say goodbye and good night, and thank you very much, all 110 people I think who joined online. Good to see you all, and we shall meet again, all 110 of you, next Friday. Okay, thanks very much.